Welcome back, everyone. Let us continue the second part of the day, and we will start with Dr. Yasmeen Yahya. Dr. Yasmeen, she's a family medicine consultant working at Musa'ad Saleh Primary Healthcare Center. She has a diploma in diabetes care and education from Dundee University. Also, she has a diploma. She has a diploma in healthcare management and quality from Gust University. She is a trainer and examiner in Kuwaiti's family medicine residency program. She is also a member of faculty of primary healthcare.
Hello, everybody. Thank you for hosting me today or choosing me to as a speaker in this very successful yearly event. So I've been asked by the organizer to talk about three related topics, which are the spirometry interpretation. I will start with that, since understanding spirometry will help us to understand the diagnosis of asthma and COPD. And I'll be also briefing the bronchial asthma diagnosis and management according to the updated GINA guidelines, and also the COPD diagnosis and management according to the updated GOLD guidelines, of course, in the context of primary care. Okay, so let's start with spirometry, the basics of spirometry interpretation. So what is a spirometer? It's a device to measure the timed and expired and inspired lung volumes. So it tells you how quickly and effectively the lungs can be emptied and filled. It's of course a reliable method to differentiate between the obstructive airway disorders like COPD and asthma, and the restrictive lung diseases like, for example, fibrotic lung diseases. It can also help you to monitor the disease severity, and it's considered the gold standard for diagnosing and monitoring COPD, and also it helps in the diagnosis of asthma. So what are the important measures that you need to interpret from a spirometry? There are actually three important values only. Okay, so from all those figures and readings, you need to interpret three values, which are the forced vital capacity, or FVC. This is the maximum or the total volume of air that the patient would forcibly exhale. That's why it's called forced vital capacity after taking full inspiration. This is called the FVC. The forced expiratory, the other value that you need to interpret is the FEV1, which is the forced expiratory volume in 1 second, which is the volume of exhaled air in the first second after deep inspiration and forced expiration. So this is another important figure that you need to look at. And of course, if the airways are normal and they're not obstructed, then the ratio between these two, the FEV1 over FVC, should be high, above 0.7, which means that you will be able to exhale most of the air in the first second if your airways are normal and not obstructed. So this is the third entity or value that you need to look for in the spirometry, the FEV1 over the FVC ratio. Another or a fourth value that you can look at is the peak expiratory flow. It has limited clinical application, but may be helpful in asthmatic patients. The values of FEV1 and FVC are expressed as percentage of the predicted of normal for the patient's age and sex and height. So the normal FEV1 would be 80% and more than 80% predicted for the patient. FVC is more than 80%, and the ratio between them should be above 0.7. So these are the reference ranges that you need to put in your mind when you're looking at the spirometer. The important patient demographics that you need to, of course, enter in the machine: the patient's gender, the height, and you need to take care to take the heights without the shoes, because 1 centimeter will make difference in the readings, the age and the ethnicity. Usually the technician will put all these information, and the machine will calculate what is the predicted value for the patient. And you need your figures to be 80% of, above 80% of that predicted for your patients. This is the diagram showing how the patient actually performs the spirometer. And here, usually the technician will put a nose clip and ask the patient to take a full breath and completely fill his lung, and then blow very hard and very long till all the air is emptied, and then breathe in again until the air is full. This is repeated at least 3 times, and the patient might feel dizzy and need to rest between the attempts. It is recommended to withhold the bronchodilators if you are doing the spirometry as a diagnostic test, and not for monitoring. If you're doing as to diagnose, then a short-acting beta agonist like Ventolin should be withheld in the last 4 hours. Atrovent should be withheld at least 12 hours. Inhalers with LABA or long-acting beta agonists like fluticasone and Symbicort and Seretide should be withheld for 1 day, and long-acting muscarinic antagonists like Spirivia should be held for 36 hours. So we now know the 3 important values that we need to look at when we read a spirometry. Now let's talk about the graphs. There are 2 graphs that appear in the spirometry report. They are the volume time curve, which is the volume of air in liters against the time. And then the other curve is the flow volume curve, or sometimes it's shown as a loop like this. So I'll go through them quickly. The volume time curve, it shows the amount of air in liters, or the volume of air in liters against time. So here at 0, the patient will have forced expiration, and when he reaches the maximum volume exhaled, this is the forced vital capacity, and in this case it's 4.9 liters. And then at 1 second, the amount of or the volume of air that is exhaled in 1 second, this is the FEV1, which is 4.2 liters. In this case, of course, it's normal because the ratio between them is more than 0.7, which means that the patient was able to exhale most of the volume of air in the first second, and this indicates normal bronchioles or airways. For the volume, the flow volume loop, here the flow of air, how many liters per second is plotted against the volume. So the patient will exhale in a full force. The force will go very high up here, and then it will gradually decrease until all the volume of air is exhaled. So this distance will be the forced vital capacity. And there's no time here in this chart. So usually the machine will plot the time like this, 1 second, and then this will be the FEV1. From this graph, you can detect the peak expiratory flow, which is similar to the peak flow meter. The machine can show you like this as a loop. So this is the expiratory phase, and this is the inspiratory flow phase. And this is called the tidal volume loop. So in a normal spirometry, the FVC and FEV1 and the ratio will be all within the normal range. Of course, you know that a normal range cannot exclude all lung diseases, especially asthma. So this is a normal spirometry. As we said, we are concerned with the FEV, with the FVC, and we are concerned with the percentage of predicted. So here it's 1 or 3 above 80%, then it's normal. Also, the FEV1 is 108. This is above normal. And then we want to see the ratio. It's 85%, above 70%. So this is normal. And you can see here the graph. The dotted line is the expected or predicted for this patient according to the demographics. And his performance is much better than the predicted for his age. So this is the normal spirometry. Now let's differentiate between the restrictive and obstructive patterns. The restrictive ventilatory pattern is when there's a problem in the lung itself, or the lung, so the lung volume is reduced, and that's why both the FVC and FEV1, they're both reduced, and they're proportionally reduced. So here, usually the FVC will be reduced less than 80%, FEV1 will be reduced, and because they're both proportionally reduced, the FEV1 will be, or the ratio between them will be normal or near normal. And contrarily, in the obstructive pattern, because both are also reduced, but they are not disproportionately reduced. The FEV1 is the entity which is markedly reduced above 80% because of the obstruction of the airways. And the FVC might be normal or reduced, but to a lesser extent than FEV1. That's why the ratio will be reduced less than 70%, and this will gives us the difference between the restrictive and the obstructive ventilatory pattern. So mostly the FEV1 over FVC ratio is the things that differs between both. Usually less than 70% ratio tells us that there's an obstructive disease, but just bear in mind that in elderly, near 70% could be normal. In all cases, if you find the value of FEV1 over FVC above 70%, then you can rule out obstruction or exclude the obstruction. So this is the pattern in the volume time loop. And you can see that in the obstructive, the steep rise here, the curve here is a bit flattened, and the FVC is reduced, but the FEV1 is markedly reduced. That's why the proportion will be less than 0.7%. This is also the spirometry pattern when there is an obstructive disease. So for FVC, you can see it's normal, the predicted 84%. FEV1 is less than normal, 65%. And we said that we want it to be above than 80%. And the ratio is 61%. So this is an obstructive pattern. And you can see that the flow volume loop, it's a bit concave and scooped contour of the curve. If you find an obstructive pattern, then you should do a reversibility testing. It's advised to do a reversibility testing. So you will administer salbutamol, which is 4 puffs of Ventolin inhaler or 1 ml of Ventolin nebulizer, and then repeat the test after 15 minutes. You need 2 things in order to say that the test is reversible, or the obstruction is reversible. You need a rise in 12% and a minimum of 200 ml increase in either FVC or FEV1 or both. Okay. So for example, in this spirometry, there's a significant bronchodilator response. So first of all, the FVC is 114%, which is normal. And the FVC is FEV1 is reduced, it's 75%, and the ratio is less than 70.7. which means that there is obstruction. This is pre-bronchodilator. After administering the bronchodilators, you can see that it was 3.3 liters, and now it's 4.6 liters. So this is more than 1.2 liters increase. So this is 1,200. We need 200 ml. So we need 0.2 we will need this figure to be 0.2 higher to say it's significant. So we wanted to be like 3.5 to say it's significant. Now it says it has increased to 4.6. And you can see also the percentage of change, we needed 12%, and it's here it's 40%. So this is signifies or this is considered a significant bronchodilator response. And you can see here that originally in the green, was the performance, and after the bronchodilator, the curve has improved. In the restrictive pattern, the FVC is markedly less than the normal, and this just shows you the difference between a restrictive pattern and obstructive pattern, how the shape of the curve is different. And the most important, you'll see the FEV1 over FVC ratio is the best things to differentiate between them. This is a restrictive pattern of spirometry, and you can see that the FVC is 28%, much lower than normal, which is 80%. The predicted FEV1 ratio is also 30%, but the ratio between them is 87, which is normal. And you can see that the flow volume loop is very narrow, which indicates that all the lung volumes are low. So when we read the spirometry, what are the steps? You need first to, of course, to check the patient demographics are correct, and then review the clinical history, because you need to consider the clinical context. You are not just reading a spirometry or a paper. You have a patient in front of you. You need to know the clinical history, and then it's important also to see that if the quality of the test was done, and the quality of the result should have been done correctly. And this is usually the technician job. He would write the comments if the patient was able to perform the spirometry correctly or not. Common things that the patient have extra breath or coughs during the effort, and this during the procedure, and this should be repeated. And then you will interpret the findings. So this is the usual, what we usually get. This is actually from our clinic, from in primary care, the spirometry machine that usually we get from the company that we arrange for in the asthma clinic. And you can see that it has a lot of numbers. The main two graphs are the volume time, but this is because the axes here are different, the X and Y axis, so you can see it a little bit, curved opposite to the pictures that I show you. And this is the flow volume loop. You don't need really to concentrate on the graphs as much as the numbers. So you can see that he will write for you a summary of the best values. So this is the box that you need to concentrate on. Neglect all the figures down. And the FVC here, it's 86%. The FEV1, it's 86%, and the ratio is measured 84%. So this is normal spirometry. This is the what comes from in the screen of the operator or the technician, but this is the piece of paper that the patient will hand you. So let's go through a few of cases here. So here, this is a 65-year-old female, has progressive dyspnea. So if you see FVC is 53%, lower, of course, than normal. FEV1 is 54%. FEV1 over FVC is 0.79, which is normal. So what is this? What's the diagnosis here? It is restrictive lung disease, because as we said that in restrictive, the FEV1 of FVC will be normal, but these two values will be low. And this for an 80-year-old male, you can see that the FEVC is 64% low, FEV1 37% again low, and the FEV1 over FVC is 41, which is also low. So this is an obstructive. Post bronchodilator, you can see that FEV1 increased more than 12%, 15, but if you want to check the volumes from 0.7 to 0.89, this is less than 200 mLs. So this is not considered a significant increase or bronchodilator response. So this is a COPD, since it didn't respond to the bronchodilator. This is again, it shows that the FEV1 is the FVC 97% normal, but the FEV1 53%, and the ratio was, the measured was, excuse me, the measured was, I don't know, I lost it, but so yes, it's this one, 46%, which is low. And then after administering the bronchodilator, you can see that the values, the percentage of change are all above 12%. The FVC has increased to 23%, the FVC1 over 75%, and the liters, of course, it's more than 200 liters, because 200 mLs. You can see that it's one more than liter. So this means that there's a significant bronchodilator effect after or reversibility, and this signifies it's asthma. This is also the last case from our clinic, and you can see that the FVC and FV1 both are less than predicted, and the ratio is 43%. So this is also signifies that there's a severe obstruction. And by the way, at the end of the report, there will be an interpretation, which is very severe obstruction, and also there's a comment on the quality. They didn't do they didn't administer bronchodilator for this patient. So this is obstructive lung disease, but we don't know if it's asthma or COPD. So this summarizes the spirometry interpretation, or the basics of spirometry interpretation. Moving now to the bronchial asthma diagnosis and management in primary care based on GINA guidelines 2023. I'll be talking about how to establish the diagnosis of bronchial asthma, and I will overview the asthma medications that are available in primary care, and how to assess and manage stable bronchial asthma, and how to manage acute exacerbations. So this pictures tells us the basics of the underlying pathophysiology of asthma, which is chronic airway inflammation. There is chronic inflammation in the airways that makes them thick, and there's a lot of mucus production. That's why they become obstructed or narrowed. And this diagram is very helpful when you want to explain diagnosis of asthma for your patients. To diagnose asthma, you need two important steps. The first is that you need to have characteristic symptom patterns from the patient's history. And then this, you need to verify then your findings by having evidence of variable expiratory airflow limitations. So you need to make sure that there's airway obstruction, and this is a reversible or variable airway obstruction. So let's go through this case. A 25-year-old male present with recurrent attacks of chest tightness, cough, and wheeze. Which of the following decreases the probability of asthma in this man? Worsening of symptoms at night, chronic sputum production, symptoms vary over time, or history of smoking? The answer is chronic sputum production, because this is not normal for patients with asthma. So in history, you need to collect all the evidence or that support or increase the probability of asthma. The things that increase the probability of asthma in history, if your patient has more than one type of symptom, like for example, more wheeze, shortness of breath, cough, chest tightness. And if their symptoms often worse at night or in the early morning, and if they vary in time and intensity, if they're triggered by certain allergen exposure or changes of weather, or by exercise or irritants such as fumes, smokes, or strong smells, and if they appear or worsen with viral infection, the symptoms. And the last thing is not really specific for asthma, but having a family history of asthma or personal history of allergic rhinitis or eczema. These all will increase the probability of asthma. So you need to ask about all these aspects in your patient's history. What would decrease the probability of asthma if the patient have only isolated cough without other respiratory symptoms, if you're having chronic production of sputum. So here you think about some other differentials like bronchiectasis, or if you have shortness of breath associated with dizziness, lightheadedness, or peripheral tingling. This, of course, would mean that maybe having panic attacks and presence of chest pain. You need also, in your initial assessment, to ask key questions to rule out other differential diagnoses. And these are the common conditions or differential diagnosis of asthma for each age group. So, and now, of course, after history, we usually do physical exam, but here the role is really limited because it's often normal in patients with asthma. Of course, you will check the ENT if you have nasal polyps or having allergic rhinitis. You listen to your the chest exam. Having expiratory wheezes can increase the probability of asthma, and you also need to measure the BMI. So if your patient have a high probability of bronchial asthma, which is by history and exam, which one will be the most appropriate next step in management? To perform a spirometry or perform a serial peak expiratory flow readings, or start SABA and see the response, or start a trial of, which is short-acting beta agonist, or start an inhaled corticosteroids. So the answer is A. It is advised to test before treating whenever possible. And I know that both A and B could be correct, but spirometry is more reliable than peak expiratory flowmetry. So if you have spirometry available, then it is better than the peak flow. This is the diagram in GINA guidelines, which tells you the steps and when you after taking detailed history and if it's the history exam supports the asthma diagnosis and he's not currently on control, then you should do the spirometry or peak flow and then treat for asthma. And unless there is a clinical urgency or other diagnoses are unlikely, then you can start empiric initial treatment. Then we said that we need in history a supporting like data from history to support the diagnosis. Then the other step, we need to have evidence of variable airflow limitations. So here also we need to document two things. We need to document that there's an expiratory airflow limitation, obstruction, which we just mentioned in the spirometry, and FEV1 over FVC below 0.7%. And then we need to document that there is excessive variability in lung function, which is also, we mentioned in the spirometry that there is a bronchodilator responsiveness, and after administering the reversibility of the test after administering the bronchodilator. So usually you need to document that FEV1 over FVC is reduced at least once through all the patient's visits or history, especially when the FEV1 is low. And then you need to confirm that there is excessive variability in the lung function. You need the more the variation, then this confirms the diagnosis of asthma. So you need to one of or more of the following. We discussed earlier the bronchodilator reversibility after administering salbutamol, the 12% and 200 ml increase. There's also, if there is an excessive diurnal variability from a 2-week, twice daily peak flowmetry monitoring. So if the patient has a peak flow meter or decided that he wants to buy a peak flow meter and he will do it every day, morning and evening, and then you will check the variability. And if it's more than 10%, then this means that there is a diurnal variability. Or if you administer a controller treatment and you see a rise in FEV1 above 12% and 200 ml, or the peak flowmetry becomes better by 20%, or there's an excessive variation in the lung function between visits, also 12% and 200 ml of variation of FEV1. That's why here spirometry is helpful in asthma more than peak flowmetry. If the initial testing is negative, then you might repeat the test when the patient is symptomatic, or when you hold the bronchodilator, or refer for additional tests, which are the exercise challenge tests or bronchial challenge tests. It is advisable to measure the lung function at the diagnosis, and then 3 to 6 months after starting ICS, and then periodically every 1 to 2 years or more often. Let's now revise the asthma medications that are available in primary care. We can divide them into relievers and controllers. The relievers are the short-acting beta agonists, which is called SABA, and the short-acting anticholinergic, SAMA, and also one of the relievers is the short-acting ICS and the short-acting LABA, which is formoterol. The controllers, I'll just go through them here again. So these are the relievers. So we have the SABA, the short-acting beta-2 agonists, and what we have from the SABA group in the clinic is the Ventolin, the salbutamol, and from the SAMA we have the tropium bromide, the Atrovent. And for the low-dose ICS plus formoterol, which is a LABA, but it's a fast-acting LABA, and it's what is only licensed for as a reliever is the Symbicort, the budesonide formoterol. I know that we have another inhaler, which is the Flutiform. It also has the 125 has low-dose ICS and formoterol, but it is not licensed, has gained the license to be used as a reliever. So I'm not going to go through the details of each and every medication. They're available. I will share with you my slides, and you can go to my slides to refer them to refer to them at any time. But for the Ventolin, it's the main action is that it provides very quick relaxation of the smooth muscles of the bronchioles. It's why it's used as a rescue medication. The Atrovent also relaxes the small muscles, but the effective it is slower effect than the Ventolin, and also it is less effective than the Ventolin. But if you combine it with the Ventolin, especially in severe attacks, then it gives the synergistic effect of Ventolin. So it increases the bronchodilation compared to Ventolin alone. That's why it's advised to combine it with Ventolin in case of moderate or severe exacerbations. And just make sure that you protect the patient's eye from the nebulized drug, because especially when combined with Ventolin, it can cause acute angle closure glaucoma. Very rare, but it's better to avoid that. And we said that we have the Symbicort that is licensed to be used as a reliever or a reliever for patients who have, especially who have mild asthma. Here we call it anti-inflammatory reliever or AIR. And also for those who are taking it regularly, as it's mentioned in the guidelines as MART, which is maintenance and reliever therapy. So these are the drugs that we have as relievers. Now let's come to the controllers. The controllers, we have the inhaled corticosteroids alone and inhaled corticosteroids combined with LABA and leukotriene modifiers. And the latestly we've had the Spirivia, which is long-acting muscarinic antagonist, tiotropium. In general, inhaled corticosteroids are the most effective anti-inflammatory medications for asthma, and they reduce the symptoms, increase the lung function, and improve the quality of life. So they're actually the mainstay of treatment of asthma. And we have the ICS combined with LABA, and in addition the addition of LABA improves the symptoms and lung functions more and reduces the exacerbation. We also have the leukotriene modifiers, which is montelukast. It blocks the action of leukotriene D4 and decreases the inflammation. It is less effective than low-dose ICS when used alone. So in comparison, it's not as effective as ICS. And even when you add to ICS, it is less effective than ICS plus LABA. The thing is that it can cause risk of serious behavior, and the FDA had a boxed warning about the serious mental health side effects of for asthma and allergy, and they advised to restrict its use for allergic rhinitis or asthma with allergic rhinitis. And lately, we had the introduction of tiotropium, which is a long-acting muscarinic antagonist. It relaxes the airway muscles and prevents bronchospasm. And it's given, this is the dose that we have in the primary care. It's given as a 1 inhalation per day. And you need to be aware of the doses of ICS for each inhaler, because it's important to when you're taking the stepwise approach, you're going to see that you need to start with the lowest dose, and then you can go to the medium or high dose. So for each bronchodilator or inhaled corticosteroids, you need to know the low and medium and dose according to the type of cortisone. So this is the budesonide. So 3 and above puffs is, for example, is considered medium dose. 6 and more puffs is high dose, because this is the concentration that we have in primary care, 160. And for the fluticasone, we have also two concentrations. And for the 250, it is, if you give twice per day, this is already a medium dose ICS. Similarly, the seretide, which comes only in 250, giving 2 puffs per day, this is considered a medium dose. The seretide 500 is already 2 puffs per day is the highest dose. And for the 6 to 11 years, we only have the Pulmicort, and these are also the we have Pulmicort in 2 concentrations, and this is the how many mLs is considered low and medium and high doses. These 2 tables can help you to know the low and medium high doses, and these are the 3 kind of ICS that are available in primary care for 12 and above, and this is for 6 and 11 years. Before, you used to have the beclomethasone 50 inhaler, but not anymore. Now it's 250, so it's already not very useful for this age group. So the only thing we're having for this age group is the budesonide nebules or Pulmicort. Okay, now let's move on to the assessment of patients with stable asthma. In history, you need to consider the 4 C's, which are the compliance, control, complications, and comorbidities. I will go through them in detail in the next slides. The ICE and impact of life, of course, is very important. Psychological and socio-economic history, physical exam, and if available, you can do peak flowmetry and spirometry. And it's also advised to do CBC for blood eosinophils, because I will show you later that high eosinophils can indicate higher risk patients. So in the compliance, you need to check that if the patient adheres to the medication, if he is doing correct inhaler technique, and if he's avoiding all the triggers and allergens. So these are the 3 elements in the compliance that you need to check with your patients. And the control, this is very important. You need to assess the control in each and every visit. How do we assess the control? By 3 or 4 questions. How frequent how frequent is the day symptoms, and how frequently the patient is using his rescue medications, if there is any night symptoms, and if there is any limitation of activity. And we know that according to GINA, a well-controlled patient should have, in the past 4 weeks, should have the daytime symptoms not more than twice per week, and should have 0 waking or night waking due to asthma. So he shouldn't have any night symptoms, and he shouldn't have used the SABA reliever more than twice a week. And be careful that this is not including, if the patient is using ICS formoterol reliever, you will not as a inhaler, as a reliever. I mean, if the patient is using Symbicort as a reliever, then you will not count it here. This is only for Ventolin. And then any activity limitation, there should be no activity limitation in patient with asthma. So this tells us that patient is well controlled. If any of these are present, 1 or 2, then he's partial controlled or even uncontrolled. This really doesn't matter. If your patient is not controlled, means that his treatment is not optimum and you need to step it up. Okay, so these are the 3 important things that are the 3 questions: the CROM, day, night, and exercise. To continue the 4 C's, the complications, you need to ask if they had any severe exacerbation in the last 12 months, or he has been ever intubated or admitted to ICU, and also the corticosteroids side effects, especially if he's using frequent oral corticosteroids or high-dose ICS. And the comorbidities, the obesity, chronic rhinosinusitis, GERD, and anxiety, depression. And treating these comorbidities can improve the asthma condition in your patients. These are the risk factors for asthma. Yes?
Sorry for interrupting you, but we have 5 minutes left.
Well, I've started. Okay. I thought that I have like 1 hour. So we started on 6:50.
Yes, we have section for questions and answers at last.
Okay. Well, to be honest, I don't think that I'm going to finish. So just give me maybe 10 more minutes.
No problem, doctor. Thank you.
Thank you so much. So for the risk factors for poor asthma outcomes, you can read these 3. They're covered all in the 4 C's, but here having high blood eosinophils and can increase the risk of poor asthma control. And then we'll move to this stepwise approach in the management. So the first step is for adults above 12 years is to use as needed low dose ICS formoterol, And then step 3, to use it as, so here Symbicort, basically as needed, and then Symbicort maintenance, and then more dose of Symbicort, and then the last step is to add LAMA. This is the preferred track. The alternative track is, especially if Symbicort for non-coatis, for example, you cannot give Symbicort. So here he will take ICS whenever SABA is taken, and then low dose maintenance ICS, and then so maybe here Bicotide, and then here maybe Flutiform 125, and then here maybe Flutiform 250, and then you should refer. So now, if the patient comes requesting Ventolin and he had his inhaler almost daily over the last month, but he has no trouble in breathing while sleeping or exercising, which of the following is the most appropriate treatment option? The answer is the regular low-dose ICS plus formoterol. How do we know that? There's this graph that shows you what's the preferred initial treatment according to the patient's symptoms. So if the patient has symptoms most of the days or waking with asthma once a week or more, like the scenario that we, then the preferred step is the low-dose maintenance ICS formoterol. These are, I will just skip a few slides. This is similar with for children from 6 to 11 years. The steps, of course, are not the same. So here, you'll give low-dose ICS in step 1 whenever the SABA is taken. And here, daily low-dose ICS. Here, you can give formoterol as Symbicort, but it should be very low dose, which is not available in our primary care. It should be 100 or 80. And then for the medium dose, you can give the dose which is available in our the Symbicort, which is available. So this, if you give Symbicort 160, this is considered a medium dose, and it's considered step 4. Similarly, if according to the patient symptoms, the starting treatment is denoted here. Now, how often would you check the response? It should be, you should actually after 1 to 3 months after treatment has started, and then every 3 to 12 months. Usually after exacerbation, you should check within 1 week. So usually, what I usually do is checking in any change of treatment. I must see the patient in 1 month. Then, if he's okay, then I can give him 2 months or 3 months appointment. Of course, if he's not controlled, how would I assess control? Through the questions that we've just the 4 C's. If he's not controlled, then you need to go 1 step up. You can also do a short term step up and instruct him if he has a viral infection or seasonal allergy exposure, automatically increase your inhalers concentration or strength for 1 to 2 weeks. And if he is controlled for minimum of 3 months, this is minimum, well controlled, then you can step it down by decreasing 20 or 50% of interval. These are the indications for referral. I'm just going quickly through them. And now let's move to the management of asthma exacerbations. The exacerbation, of course, are worsening of the symptoms, acute worsening of the symptoms. And Gina divides them into mild or moderate and severe. And if the patient is talking in phrases and has respiratory rate increase, but not more than 30, not using accessory muscles, the pulse rate is between 100 and 120, and the oxygen saturation is above 90%, this is mild or moderate attack. So here you'll give, of course, Ventolin, you give prednisolone, 40 to 50 milligrams, and you'll give oxygen if needed. If the attack is severe, then you should arrange for transfer, and while awaiting, you should give SABA along with Atrovent with Ventolin, oxygen, and IV hydrocort 100 milligram. And you should follow him closely after the exacerbation. Now let's move to the COPD. The COPD is, of course, a group of lung conditions which are characterized by chronic respiratory symptoms. They are broadly divided into bronchitis or bronchiolitis and emphysema. The characteristics that they're persistent and there's progressive airflow obstruction. The causes and risk factors for COPD. Yes.
I'm so sorry for interrupting you again. We can extend for an extra 10 minutes if it suits you.
Yes, thank you so much.
Thank you, Dr.
The causes are could be from genetically, especially alpha-1 antitrypsin deficiency. And this is if we will suspect if you see a young patient with the obstructive pattern, which is not reversible. And also, mostly it is caused by the environmental exposure of cigarettes, smoking, or exposure to pollution, like household pollution or air pollution or wildfire smokes. And some also COPDs can come after infections like TBs or HIV-associated COPD. So these are the common causes of COPD. And you should consider the diagnosis of COPD in a patient presenting with any of these, with dyspnea, that's progressive over time, or with patient with recurrent wheeze, or chronic cough, or recurrent lower respiratory tract infections, or history of exposure to risk factors like tobacco smoking and occupational dust. So here you should consider the diagnosis of COPD and do a spirometry. So the history, what are the important aspects if you are suspecting a patient with COPD? Of course, you need to ask about the pattern of symptom development. Usually the patient will tell you that he's been for a long time, he has been having cough with increasing breathlessness and or prolonged winter colds. Patient's exposure to risk factors. Past medical history, which includes the early life events, like if he's premature or have maternal smoking during pregnancy, or he has passive smoking. Family history of COPD, history of exacerbations or previous hospitalizations is very important. Presence of comorbidities, impact of the patient's life, social and family support, and possibilities of reducing risk factors, especially smoking cessations. And of course, you need to put in your mind that we need to ask key questions to differentiate other possible differential diagnoses, namely asthma, congestive heart failure, TB, lung cancer, chronic allergic rhinitis, gastroesophageal reflux. So now, if you have a patient who is a smoker for 35 years and have chronic productive cough and dyspnea on strenuous exertion, which of the following is the investigation of choice to establish the diagnosis? Chest X-rays or CT scan or spirometry or pre-flow expiratory flow? The answer is spirometry. This is the investigation of the most reproducible and objective measurement for airflow obstruction, and it's the gold standard to diagnose COPD. And we said that we need the FEV1 to be of VC to be less than 0.7 post bronchodilation to confirm the diagnosis of COPD. Chest X-ray will not help you to diagnose COPD, but you might need it to exclude other differential diagnoses. And also chest CT imaging might be considered for those who have persistent exacerbations or low FEV1. So spirometry is very important for the diagnosis and also to assess the severity and to follow up assessment. Now, in the initial assessment, you need to detect the severity of airflow limitation. This you will detect it by the spirometry reading, okay? And then the next step, you need to take history about the nature and magnitude of the current symptoms and the previous history of moderate and severe exacerbations. and the presence of multimorbidities. So the severity of airflow obstruction, you will detect it from the spirometry reading. And this is what, if the, actually after giving a bronchodilator, you will see the FEV1. If it's above 80%, then this is GOLD 1, which is mild. If it's between 50 and 80%, then this is GOLD 2, moderate, and then severe and very severe if it's less than 30%. This actually, the severity grading, clinically, it's not very important for you to decide which treatment to give. It's only for the prognosis. Okay, you need to document it for the patient's prognosis. The most important two aspects to deter or to help you or to guide you which medication to start for your patients is these two: the nature or magnitude of the current symptoms and the previous history of moderate to severe exacerbations. How would I know the magnitude or of the current symptoms? Using validated questionnaires. Okay, GOLD guidelines propose two questionnaires, which are the MRC, the Medical Research Council, and the CAT questionnaires, which is the COPD assessment tests. Okay, so according to these, they advise actually to use them both together, but you can use one of them at least. So this scale tells you the dyspnea scale. If it's 0 or 1, then there's only minimal dyspnea on maximum exertion. Then from 2 onwards, there's more dyspnea on regular daily activities. And this incorporates more than dyspnea. It incorporates cough. So this is a scale out of 40. There's 8 questions here out of 5. It tells you ask the patient about coughing and if there's mucus and having energy and sleep and all these things. So this comes to the GOLD ABE assessment tool. So we said that we did the spirometry and we confirmed that it's less than 0.7. So we diagnosed COPD and we knew the grade, which is not very helpful clinically, but just to tell us the prognosis of the patient. Then we come to the most important part. We want to categorize our patient into these 3 groups, A, B, and E. This is recently has been changed. It was A, B, C, D. This is recently changed now in the 223 guidelines. So patients in group A, they have very few symptoms or low symptoms or not so much symptoms, and here the history of exacerbation per year. They have 0 or 1 moderate exacerbation not leading to hospitalization. So these are group A. Group B are those who are more symptomatic, but again, they didn't have much exacerbations. All patients who have exacerbations more than 2 or more moderate or 1 exacerbation leading to hospitalization per year, they are now fused to group E. Okay, and this based on the assessment of symptoms and history of exacerbation, you will know which group of patients you are in, and this will help you to decide the initial treatment for your patient. Of course, you need to advise for smoking cessation. These are the list of medications that are available for COPD, but of course, a few of them, only very few are available in primary care. So I'll just discuss the things that we can do in primary care. So for this patient who has GOLD 3 COPD, and he has frequent exacerbations and limited exercise tolerance, what do you think is the most appropriate initial treatment option? Actually, it's LABA and LAMA. How do we know this? By this graph. This graph tells you what's the initial pharmacological treatment for each group of patients. So for group A, those who have few symptoms and no exacerbations or few exacerbations, then a bronchodilator is the initial treatment option. Group B, we will have LABA plus LAMA. And of course, we don't have in primary care, and I don't know about secondary care, but LABA alone is not available in primary care. We only have LAMA. And in group E, those who have a lot of exacerbations, then the advice is LABA and LAMA, and you might add ICS if the blood eosinophils is more than 100. So we can, because we have LABA and ICS inhalers, So we can here add the ICS. So if you want to see what available options we have in primary care, for group A, we can give either Ventolin or Atrovent or Spirevia, and Spirevia is preferred, LAMA is preferred over these two, to be honest, as per the guidelines. For group B, we only have LAMA alone. So usually if they're not responding to LAMA alone, then we should refer them. And for group E, you can give Spirevia plus any of the ICS LABAs that are available, only if the blood eosinophils is above 300. And this guides you when you should start ICS. It will, if there are more than 2 exacerbations of COPD and the blood eosinophils of above 300, then this strongly favors the use of ICS. Because, you know, the use of ICS is associated with increased risk of pneumonia. That's why you don't want to start it to everybody, especially high doses of ICS. And of course, if it's not if the patient is not controlled on one treatment, then you can combine both treatments. And in other secondary care or maybe other countries, LABAs and LAMAs are available in a single inhaler. This is where it tells us that combination of SABA and SAMA are superior, and LAMAs have greater effect than LABAs. And here's where they tell us that LABAs and LAMAs are preferred over the short-acting. So for group A patients, Spirevia is preferred over the Ventolin or Atrovent, unless it's very, they have very mild or symptom, like occasional dyspnea, then Ventolin will be enough for them. Long-term therapy with ICS is not recommended, and it's not encouraged to use ICS and LABA alone, like, for example, Seretide or Symbicort alone for patients with COPD. This is not advised at all. Okay, so it's should always be combined with the Spirevia. Here it tells you that you can use mucolytic agents, but not antitussive agents. So maybe mucolyte can be used, although the names here, the mentions are different than the mucolyte, but antitussive like Cafosid or Amidramine, they're not advised to be used. Of course, you need to do smoking cessation and education for your patients, encourage physical activity and healthy diet, vaccinations like influenza, COVID-19, pneumococcal, and shingles, and do lung cancer screening, and other patients can benefit from pulmonary rehab and oxygen therapy, and maybe some interventions like bronchoscopy. You know about the 5 A's to help patient to quit smoking. Let's talk quickly about the exacerbations. For the exacerbations, the GOLD guidelines divide them into 3: mild, moderate, severe. And 3, and the mild, they do dyspnea. They call it as visual analog scale for dyspnea. So depending on your vision, if the 5 and above is when the patient's having severe dyspnea. Okay, so if the patient is not very dyspneic, his respiratory rate is below 24 breaths per minute, his heart rate is less than 95, and resting SpO2 is above 92, then this is a mild exacerbation. If he's dyspneic or the respiratory rate is above 24 or the heart rate is above 95 and the SpO2 below 92%, then this is a moderate. And you can see that in the severe, it's exactly the same as moderate, the parameters, but the only difference is the ABG finding. That's why it would be very difficult for you in the primary care to differentiate between a moderate and severe exacerbation. For mild exacerbations, you will treat with only short-acting bronchodilators like Ventolin, okay, or Atrovent. For moderate, you can treat them with short-acting and oral corticosteroids and plus or minus antibiotics. But like I told you, in our setting, it's better to refer because it will be difficult to differentiate between these two. And of course, for the severe, you need to refer. This is the proposed follow-up checklist for patients with the COPD. And to summarize, the spirometry should be performed to establish the diagnosis of COPD in suspected patients, and you need to determine the severity of symptoms and number of exacerbations. These are the most two to decide on the initial pharmacological treatment. Thank you for your attention, and sorry for taking more time than intended. I covered 3 topics, so maybe this is...
Thank you. Yeah. Thank you so much, Dr. Yasmeen, for this amazing and informative lecture. It was really a pleasure to have you. It's really a big and a huge topic, and due to the high demand, we extended the time for you. We are so sorry that we don't have enough time to cover the questions, but they can for sure contact you personally if they have any other questions. It is really a pleasure again, Dr. Yasmeen, to have you, and we hope you join us every year, inshallah.
Thank you so much. Thank you.
Thank you.
And I will share my slides with everybody for
yes,
their reference.
Thank you so much. Thank you, Dr. Yasmeen.